Okay, so this is for strokes. You have two main types of strokes. You have ischemic and hemorrhagic, and then you also have something called TIA. So with your ischemic, you have two subtypes. You have like embolisms and thrombosis. So what's the difference between these?
One moves, another one don't.
I mean, yeah, like ultimately that's exactly what it is. Embolism be moving. Embolism is usually caused by something like your AFib. Have you guys gone over like cardiac conditions like that yet? If not, it's okay. Just like the slight patho behind it. Yeah, mostly AFib will be your cause of the embolism ones. But the reason that happens is because for AFib, quite literally what it sounds like. Your atrium are just fibrillating. They're not contracting, they're just quivering. And when you have blood that sits, because since it's not pumping properly, it just sits, it clots, right? So if it's up at one of the atria, it'll go down into the ventricle and eventually it'll make its way out. So if it's on the right side, it might get stuck in the lungs as it goes through the like pulmonic vein, artery, that kind of stuff. Or if it's on the other side, it might shoot up out of the aorta into the brain. Love that. Anyway, so your patients with AFib will usually take warfarin. Depends where you're at. Usually I see there we go, Elicus. It is a very expensive medication though, so some places you'll see it, some places not. So warfarin, Elicus, some kind of anticoagulant in order to prevent that. And then thrombosis, exactly what it sounds like. It don't move. Not really, it's not moving too much anyway. Okay, let's tap paste that. There we go. I'm really bad at like typing and talking. He's good at it, I'm not. So I copy paste my stuff. Sorry. But yeah, so atherosclerosis, I'm sure you guys went over that already. So the plaque causes ischemia because it's constricting the blood vessel too much, letting it get through, and boom, bada bing, bada boom, get a stroke. Yay. Hemorrhagic is pretty much exactly what it sounds like. It's a bleedy stroke, bleedy, bleedy. Oops, there we go. Bleedy. I always call it the bleedy ones. I don't know. And then what's your TIA? Back cracked. Transient ischemic attack. Yeah, it's a mini stroke essentially. So not full blown. The symptoms are usually very short acting, so people kind of take it with a grain of salt. They're like, oh, that was weird. Don't think much of it. And then they end up having a ischemic stroke. So if somebody is experiencing TIA or a mini stroke, they should still go and get evaluated, get the proper treatment for it so that it doesn't lead to a full-blown stroke. Love that. All right, you guys heard this acronym before. Be fast. It's posted on every hospital wall. What's B stand for? Balance, also known ataxia. So are they able to walk, stand, that whole bit? What's the E? Yes, eyesight. So they might say blurry vision. They might say it's like dark, floaters, whatever the case. Something wrong with their eyes. The F is for friends. Facial symmetry. Yes. So face. We're looking for asymmetry. I think that's how. Yeah, that's how you spell that. Okay. I'll go through the rest of them. It's okay. Okay, so A is for arms. That's not how you spell arms. A is for arms. You're also looking for asymmetry in that. Does anyone know what that means for arms? So I get it's kind of like funky. Like, what do you mean asymmetry for arms? If not, it's okay. I can talk about it. but I'm not sure if they went over like what to look for. Yeah, so strength is one of them. So you could do that by your hand grips, which you guys went over with your physical assessment all the way back when in first semester. Oh my God, like first 2 weeks, guys, like crazy stuff. I feel like nobody does the grip strength or like the foot pushes at one point, because for most of your patients, there's not too much of a problem with it, but when any of your neuro ones, stuff like that will be very, very important. I'll go over it a smidge later. I won't go too in depth on it, but one of your assessment tools for stroke is a NIH scale. Don't ask me what NIH stands for, but it's a stroke scale. Something National Institute, something like that. Yes, balance between the level of the arms. So part of the criteria for it is you'll have them like raise their arm. I think it's like 45-degree angle. You'll have them keep it there and you'll count to 10. And there's different levels, different numbers that you can assign based off the result, and you grade each arm. So if it stays up, it doesn't move, awesome. Like they're doing great. That's full points. Get a point knocked off if it starts to drift down a little bit but doesn't hit the bed. You get another point taken off if it hits the bed but it comes back up off the bed. You get a point knocked off if you like if it just drops, and then if there's absolutely no movement at all, like that's big bad. Like they're not even moving that side at all, that's like 0 points, unfortunately. So that's what they mean by arms. As for speech, so known as your aphasia, I would definitely know the big words for it. I know like in report whatnot, sometimes you'll hear like people just skip over like the fancy terms. I'm one of those people where I try to skip over the fancy terms because they're very big for me, and it makes more sense for me to just say, oh, like their deficits are with speech and whatever else. But yeah, definitely know it because they will not use a lot of the like simpler words on your tests and whatnot. And then T, so 2 things with this. So time to call 911 if they are outside of the hospital, or RRT if you're in the hospital. Time to call somebody. Somebody finna get called. And then also T for time. So note the last known well time. Oh God, I'm typing this, sorry. Known well time. There we go. What that means is like if they were inpatient and you did your assessment at 12 o'clock and you come back at 12:45 and you notice that they seem off, you call the RRT and they're like, oh, this code stroke. They're gonna ask you, well, what's their last known well time? Last time you assessed them was at 12 and they seemed okay or better at that point. So you'll say like that was their last known well time. Outside of the hospitals when it gets a little tricky, and that is very important to know that because it also guides your treatment. We'll go into the treatment of that a little bit later. No worries on that. I would know the functions of both sides of the brain. So left for logical, and ironically, it controls the opposite side of your body. So physically, opposite side. L for logical. So reading, I really thought that said Alexa, sorry. I looked at this and I was like, Alexa. No, Alexia for reading. Writing a graphia, I think like graphite, like the pencils are made of graphite. Speaking, aphasia, and math, like how to add stuff in your head. Right brain, this is a far stretch. This is like Nurcera stuff right here, but creative. So think about the R in creative for right. So memory, emotional intelligence, impulsiveness, and balance. Balance is kind of in my head, it's kind of like the wonky one out of the few. I always, for some reason, thought that balance went with the left brain, but it goes with the right. Yeah, so those that have issues of the stroke where it was affecting right side brain, they'll present differently than those with the left. They might be a bit more labile with their emotions. They might just be like talking to you and all of a sudden they're like, screw you, get out. Like in the middle of a sentence, like weird stuff. Anyway. So I always had a problem with this one, aphasia, agraphia. I just put it in here if anyone else has an issue with it. Just the basic definition of it. not too bad. So aphasia, language impairment, agraphia, can't write. Graph for graphite. Cool, cool, cool. All right, so interventions. We'll just start with like general interventions for both. So what are we thinking, guys? I'm scrolling on the wrong side. There we go. All right, what kind of like screening would you want to do when they come in? Yeah, of course, we want a CT. So we're doing a CT without contrast. Reason being, we want to make sure they're not having a bleedy stroke. Bleedy stroke equals bad. So this one is really important because of our TPA, right? What happens if I give TPA to someone with a hemorrhagic stroke? Oh, NIH is a good one too, yes. Why is it, what the heck? Why is it doing this? I give up. And what? Why is it typing in Japanese? Fucking, yeah. Hold on, I gotta get Diego up. I don't know what I did to his keyboard. Diego, your keyboard's typing in Japanese. Why is it typing in Japanese? What did I do? Help. Why do you have Italian on here too? How often do you write in Italian? Okay, thank you very much. You can go back. I'm so sorry, y'all. I don't even know how I did that, but there's like a little corner of the thing every day when you eat. Yeah, I was like, dude, how often are you writing in like kanji? For real though. But in any case, so yeah, TPA, there we go. Finally. NIHSS, another important screening tool. Your TPA, what is the time frame for that? Less than 3 hours. From what? From the time they got to the hospital, from the time that you're like, oh dang, they need treatment. Last well time thingy. Yeah. Less than 3 hours from last known well time. Yes. So if they come in and they're like, yeah, I started experiencing this like 12 hours ago, and I just came in now, like kind of a little too late, man. Sorry. It's a little too far out. So yeah, less than 3 hours from the time that they started experiencing the symptoms. Let's see if I have TPA. Yeah, I have TPA somewhere else. So I'll go over like the more specifics of it in a bit. More monitoring you want to do, obviously. Every question ever, vital signs, right? If they have bleedy stroke, signs and symptoms of bleeding. Hopefully it's not external as well. Level of consciousness assessments, which also goes into your NIH, but oh shoot, getting a phone call too. Last thing as well is that they can have increased ICP. You guys went over that term? I think, hope.
Yes.
Okay, cool. So yeah, intracranial, actually, you guys know it. It's fine. So increased ICP. So that is your trifecta. So increased BP, decreased respiratory rate, and heart rate. Did I spell that right? I did. Awesome. As long as it's not a bleedy stroke, we could do VTE prophylaxis. So we could do like, what's the word I want to look for? Like mechanical, like SCDs. They don't really use TEDOs too often, or like the compression stockings anymore, but SCDs. So definitely learn how to set those up. Because I fight with those machines all the time. I swear to you, half of them are broken. Anyway, antithrombotics. So like your aspirin and Plavix. That's not how you spell Plavix. I swear if I put this keyboard in Japanese again, I'm screwed. And then anticoagulation. So usually, I know it says warfarin here, but usually if they're in hospital and they've passed like the time for where to go for TPA, they might be put on heparin drip as well as these other things. Let's see. In general, you also want to do statin medications because, like we mentioned earlier, one of the causes could be your atherosclerosis. So definitely want to control that so that they can continue to eat bacon because bacon is life. Stroke education, sure, we love education. Meaning like, hey man, like you're experiencing this symptom. Let's say they have dysphagia, the ED one, the one with the G. Like, hey man, you might want to be a little bit careful when you chew and when you swallow. We have to thicken your liquids because you're having a hard time swallowing and we don't want you to choke. Stuff like that. Because people will try to chow down on stuff. I've had that happen to me already. And then assessments for oh god, I forgot how to spell that. There we go. Rehabilitation. So again, like looking at their diet, if they need a sitter or someone for feedings as well, considering PT, OT evaluation, if they need assistive devices or if their gait's really unsteady, to try to get them back on these stuff. All right, let's see here. Did I miss anything in this section that I'm aware of? I'm just looking through it real quick. That's it. But yeah, so like we mentioned with the ischemic stroke, your anticoagulant, I see osmotic diuretics here. I don't see that as much for ischemic. I feel like I see that more on hemorrhagic because that's to reduce brain swelling. Not to say that it won't happen, but usually I've seen it more consistently with your hemorrhagic because you're bleeding in your brain. It is bleeding. Your anticoags, like we talked about, and your TPA. What was it that I wanted to talk about? Oh, right, contraindications. That's important. Because I'm not gonna just give everybody like Oprah, you get TPA, you get TPA, everybody gets TPA. No, fortunately, I cannot do that. So what are some contraindications you guys can think of for TPA? Right off the bat, yeah, hemorrhagic stroke. If I get that CT back and it's like, this patient has like a 7mm midline shift and I can see bleedy, like, no. Yeah, bleeding, like external bleeding as well, right? Any kind of bleeding throughout the body. Overly hypertension. Also CI. Oh, sorry. It's like, I was like, CIA. No. Okay. Yeah, possibly as well, like extreme hypertension. I can see that being a thing. I'll talk about permissive hypertension in a little bit with the hemorrhagic stuff though. But yeah, like basically, if they're bleeding, if they had a recent surgery, right, these people are at risk for bleedy. So if they just had a surgery like 2 days ago, I'm gonna be a little bit worrisome about this person. Low platelets, or like a really high coag panels, like high PTT, PT, INR, anything where I'm like, oh, this person's taking a long time to clot. Maybe I should be a little careful about that. That's it for that. Long term, we already kind of talked about, right? So antiplatelets, anticoags, I guess technically anti-eleptics is here, but I mean, it kind of just depends on what the problem is. Calcium channel blockers as well are good for this. All right, time for bleedy stroke. So bleedy stroke is a bit more complicated in terms of its treatment. What do you guys know about the treatment for hemorrhagic? Did they just kind of go over like what it was, or did they actually go over the treatment with you guys? I think when I had this lecture, they only went over like what it was. They didn't really go over the treatment, but since it's moved to a different semester, I'm not sure really how far in depth they went. Just trying to gauge. That's all right. No worries. We'll talk about it. I was like, you can always just look back at your notes at one point or another, because I just not sure what they test on anymore. I've been out of the game too long, I guess. It's only been like, yes, been a year. Time flies when you're having fun. Anyway, so surgery is a possible thing. Basically, you just want to stop the bleeding. No more bleeding. Reduce pressure. So sometimes you'll have pressure that gets too high, it increases your ICP. Patients start to experience that trifecta, right? They have the increased blood pressure with the decreased respiratory rate, heart rate, and that's bad. And you can do a couple different things for that. I think I put it up there already, where you can do like osmotic diuretics. I had a patient one time that came in and we started him on like 3% saline, which is a high alert, quote unquote medication, but high alert. Gotta be real careful with that one, but that can pull some fluid out, right? It's like salty. For some reason, salty chicken made sense in my head, but one of my friends at my new Yap, she was like, "Oh, I always remembered it like the salty ocean, and when I go to the ocean and like, you know, I get some seawater in my mouth, like it's really salty, and then I want water after to wash it out." I'm like, I guess that works. So whatever way you remember that, as long as you just know that the 3% or anything like that is going to be pulling fluids away. But yeah. In terms of surgery, they can do clipping. Oh god, endovascular coiling for aneurysms. I was like, I'm sorry, I can't spell all that. It's too big words. Yeah. Depending on what's going on, they may put an DVD shunt in. I don't think you guys have to know it that deep. But it's just a shunt that drains outside of the body, so it's able to remove fluids from the brain. So you monitor your pressure there as well while it's draining. I won't go too far into it. But yeah, so neural monitoring as well. So again, monitoring signs and symptoms of ICP, or increasing ICP. There we go. Increased ICP, NIH, again, I think it's good before you guys get to like critical care. If you plan to go to critical care, you don't have to get the certification at this point, don't want to, but you can find like on YouTube and stuff, you can find the videos and see, just have an idea of like how it's done. Because you never know, it can happen, someone can have a stroke on any floor, you never know. Even if you're not going to critical care. Meemaw can have a stroke. Sorry, Meemaw. Let's see here. Yeah. So if you see, oh god, if you see increased ICP, call MD. Oh my god, that works. So your first signs of that is going to be like a declining level of consciousness, maybe a headache. You'll see some kind of alteration, be it minor, but you should definitely look into it a little bit further. Let's see here. Positioning is important. That's not how to spell that. There we go. Positioning for a patient with hemorrhagic stroke is important to decrease intracranial pressure or keep it within a normal range. So head of the bed. How did we get the degree thing in here? I don't know. Makes it so I don't have to type out degree. Cool. Okay, head of bed, 25 to 30 degrees. You don't want them completely flat. Making sure their head and neck are in natural neutral positions. Body is aligned. That's not how you spell that. See, I told you guys I'm really bad at typing, talking at the same time. Body's aligned, so head, you know, in line with shoulders. It's not like turned to one side or the other. It's not forward. It's not all the way back. Like it's just there. Hips are actually in line. They're not like sitting all crooked on the bed or anything like that. Let's see. There's a couple other things. I don't know how deep they're gonna go into it. I'll leave it at that. There's different positioning you can do depending on what's going on as well. So you might not be able to do like head event 25 to 30, and that's a whole other problem. But yeah, I mean, genuinely that's about it. It's not too bad. It seems like a lot, but it's genuinely not too bad. It's just as long as you know, can recognize your signs and symptoms of your neuro changes. Yeah, I was like, dude, like stroke. I didn't like stroke when I was in school, and then I dealt with a lot of strokes, and I'm like, oh, okay. Like once you start seeing it a lot more, it's like, oh, okay, like it's starting to make sense. Like you start to see the same patterns of stuff again and again and again, which helps me. But yeah, the last thing I want to go over for hemorrhagic stroke, again, this is like probably totally extra information. For those with like a subarachnoid hemorrhage, so like different part of the brain that's bleeding, they can have what's called a vasospasm. So the blood can irritate other arteries. They'll usually have like worsening of their symptoms. I had a lady when I was still in school. She was having vasospasms every day, poor thing. And so she would be extremely altered in the morning, couldn't walk, or not even walk, hold on, couldn't move, first and foremost, couldn't even move. Let's start there. Couldn't move, couldn't talk, just her NIH was really high. Higher is not good in this, decision. It's high NIH is really bad. So it would be a lot higher, showing that she was a lot worse. She would go in for treatment. She'd come back out a couple hours later. She would start to improve. Usually have like a daily nimatop. So anybody who has like bleeding hemorrhage like that, they're going to stay in the ICU, or at least they're staying in the hospital for a hot minute, because nimatop, if I remember correctly, is given for 2 weeks to try to prevent that vasospasm. You could also do something like permissive hypertension, which is kind of ironic, but the permissive hypertension allows for like, what is it again? I think ironically is that it's like more blood flow to the brain, because you still want to keep it perfused to prevent any further deficits. And then if they are having the vasospasms, on top of that nimatop, you can send them to interventional radiology to have verapamil instilled in their head. They brain. And you would assess for that with, again, your neuroassessments, your NIH, or even just looking at the patient being like, you look different than you did like 2 hours ago. Something's wrong. Or TCD, transcranial Doppler, put that Doppler on their brain. Yeah, not too bad. So I'll go over here. Let's go through, show the answers. We'll go through this really quick as well. We'll be out of here soon. Okay, so for the first question, you're caring for caring for a recently admitted patient. Which clinical finding is the earliest sign for increased intracranial pressure? I'm gonna be lazy and like copy and paste this over to the other side so I don't have to scroll up and down. I got a message that was saying there's something wrong with time cards. No, I need my money. Please, I'm broke. All right, yeah. So headache was one of them. At least out of here, that one would be the best answer. But you could usually see like that decreased level of consciousness or alteration first, but they might also be complaining of headache. All right, for 2, during discharge teaching for a patient who experienced mild stroke, you're providing details how to eliminate risk factors for experiencing another stroke, which risk factors are modifiable. I know we didn't really go over this, but they're not too bad. Yeah, right. So stop smoking, please. Fortunately, lose some weight respectfully. Get to a healthy weight and definitely, walk a bit more. I know it's hard with desk job, but be like that. So yeah, those are your modifiables. Your family history, I can't change my family. It is what it is. Advanced age, I wish I could go back and be younger, but man, can't do that. So those ones are your modifiable A, D, and E. Your patient is experiencing expressive aphasia. Select all the ways to effectively communicate with that patient. Yeah, right, B and C. So just want a simple response, yes, no, one word, short phrases, and using a communication board, assuming that they're still able to have that like hand function. Don't repeat questions, that's just kind of mean. And discourage them from using words. I feel like that's even worse because it's just pushing you down. I mean, both answers just sound mean to me, first and foremost. But yeah, for rehabilitation too, like we would want them to attempt to speak and attempt to regain that function. So I'm not going to discourage them from doing it because ultimately I'm hurting them at the end. So yeah, B and C for that. While conversing with a patient who had a stroke 6 months ago, you note their speech is hard to understand and slurred. This is what? This is a big word. Oh, and my time card doesn't show up anymore. Oh no. ADP's broken. Same. Like Mr. Krabs. My dad calls me greedy. So I'm always like, I want more money. Just have a fancy lifestyle. Yeah, so dysphagia, don't get confused with dysphagia. The G, I think G for GI. The GI is literally right here, so think GI eating. That works in my head. So yeah, dysphagia with the S. As for speech, number 5, oops, just kidding. Number 5, you're reading physician H&P report. You note that the report, you note that they wrote the patient has hemianopsia. What assessment finding in your assessment correlates with that? I was like, I got some good like ways of remembering stuff. Some other stuff, like that fried chicken one, like some of them are just so odd to me that they stuck out in my head. Like Robin's central line care for preventing collapse, scrupulous hand hygiene. That always stuck in my head. Yeah, I don't think I went over this term with you guys either. I didn't go over too many of the like signs and symptoms. I definitely went over more of the treatment feel. But yeah, so the limited vision, half the visual field, hemi referring to like, I think hemisphere, so like different parts. I don't know, that just works in my head. And then anopsia, I would just remember and or A without. I'm assuming OP is like I or something. I'm sure it is. But yeah, so limited vision in half visual field, which is also part of your NIH assessment that you. Yeah, number 6, Close enough, man. Like it makes sense, right? Like you see Hemi and it's like, okay, I know a part of something. So context clues, man. Heck yeah. All right, so number 6, you need to obtain informed consent from a patient for a procedure. They experienced a stroke 3 months ago. Patient is unable to sign the consent form. Oh God, because he can't write. This is known as what? That's not good. Yeah, right. Agraphia. The graph. I don't know if that helped anybody. The graph, I always thought of graphite, like not the mechanical fancy pens. No, the actual wooden pens with the graphite in it. But yeah, agraphia for that. All right, number 7, in order for tissue plasminogen activator, also known as TPA, to be most effective, it must be administered when, I know I already asked this earlier, but kind of just further reinforcing this one. Yeah, not before. Honestly, I felt like 3rd and 4th semester, it was a lot of like, how do I say? I almost felt like some of the stuff in the test was like, I don't want to say wordplay per se, but where it'd be like one small part of the answer makes it wrong. And that was something that I noticed in that 2nd year of school. So I'm not sure if, because it's the same instructors, kind of looking at it like, yeah, it'll probably be the same way for you guys, but just be really careful when going through your answer choices. So within 3 hours after onset of symptoms, so C on this. All right. You're assisting a patient who has right side hemiparesis and dysphagia with eating. It is very important to do what? It's a big word for elbow. Take that question mark off. Come on. Yeah, right? Because the other answer choices don't make as much sense. Keep the head of the bed less than 30. That's a bad idea. And I'll tell you why, because I did this last night. I was laying down almost completely flat. I had like a really flat pillow under my head, and I was like, you know what? I'm kind of thirsty. So I grabbed the cup of water that was on the table, and then I tried to drink it. I spilled on myself, and I started choking on it. So I think about that. Preventing aspiration by thinning the liquids. It's going to be the opposite of it. We want it thicker because, like the water that I just had, it just slipped right down my throat, and it was over for me. Especially important for your older folk too, right? They can end up with aspiration pneumonia, and ultimately that can lead to death at one point or another. So just be really careful with that. And have the patient extend their neck upward away from the chest while eating. You actually want them to tuck it down. I think it, if I remember correctly, something with like shortening how long, like that tube the esophagus is to the stomach, something like that. Oh yeah. So check for pouching of food in the right cheek because they have hemiparesis. I had to actually look up that word because I was like, it's hemi something, it's half something. So that's gonna be like right-sided on this one, right-sided weakness, and then they have the dysphagia, hard time with eating. So whenever you have patients like that, you always got to check for like the pouching of food or pocketing, especially with this person on the right side because they have that weakness. All right, so patient has experienced right side brain damage and they are experiencing neglect syndrome. I also didn't go over this with you guys today. What nursing intervention will you include in their plan of care? Yeah, right. So neglect syndrome is just referring to like they don't even acknowledge that part of their body's there anymore. Like it's almost like it's almost like it seems like they forget that it even existed. So reminding them to attempt to use and touch both sides, so that they don't completely neglect the other side. But yeah, that's that one. Which of the following are your left-sided stroke? Yeah, so A, C, E, and F. So even though it's a left-sided stroke, left-sided brain affects motor-wise the right side. So right-sided weakness on that, and then left L for logical, right? So our aphasia, the agraphia, and alexia. The impulsiveness, the balance one that I always get mixed up with left-sided, the memory, that's going to be more of your right side, that critical thinking one with the stretch of that acronym. And then for number 11, we talked about it a few times, so I'll just reinforce it. So biggest priority when bringing in a patient suspected of having a stroke. So do a CT, technically you should do an MRI too, but if you don't have the MRI machine, so CT, MRI of head to see if they're having hemorrhagic stroke or not. Because again, we don't want to give something that's gonna thin the blood to bleedy patient, because that's a good way to get a lawsuit. Please don't do that. So yeah, if they're having ischemic, there's no bleedy, then we can do that TPA, antiplatelets and the like. If they're having hemorrhagic, definitely a lot more monitoring and a lot more focus on trying to decrease the ICP and control bleed. And that is it, y'all. That is it for today. Let me save these, download these, and I will put it in the chat. At this time, if anybody has any extra questions about the stuff we went over, oh, like that. Oh, it's down. It's down. His computer saves to weird spaces. I swear to y'all. Not the goat. I've been out of it for a little too long, to be honest with you guys. Like, I haven't been able to show up as much because of my job. It's been for the first 2 or 3 weeks. It was 5 days a week, 8 hours, and that sucked. It further reinforced for me that I never want to live that type of life, and that is okay. Because like it was in the mornings, it would be like just an hour drive there, hour drive back. It's like, dang. Versus 7 in the morning getting there, it's a lot faster because nobody's driving. Not too many people are driving at 6 o'clock in the morning. Thank God. Thank God. Okay, finally I got it. Finally found it. I downloaded them, then I couldn't find the files. But yeah, so things are starting to normalize a little bit more for me with my schedule. Thank God. Although next week I have to work 4 days straight, so I might not be as into it next week. But the week after that, I should be a little bit more available, hopefully. Yeah. You guys were able to open those, right? Yes. All right.